it looks like we are live here in the Home Health Agency Growth Facebook group, and we are here with our member Eliseo. And Eliseo, can you hear me?
Yes.
All right.
Can you hear
me? You do sound good here. All right. So you and I have been friends on the internet for a couple of years now, and through some of the insurance groups that we're a part of.
Yep.
And so also have gotten to know you a little bit that way, and know a little bit about what you do for a living outside of the insurance business. And we thought that it might be a good time to bring you on and let you teach me about the medical side of what we do for a change. So why don't you real quick just kind of tell us about yourself?
So my name is Eliseo Tajanlangit. I'm a registered nurse. I've been case manager for almost 8 years now, and before that I was an ER nurse, a bedside ER nurse for 20 years. I went to Cerritos Community College in California, and that's where I worked as an ER nurse throughout all different hospitals in Southern California before we relocated to Pennsylvania about almost 17 years ago. And currently work in the Level 2 Trauma Center, where I'm a case manager. I am a case manager in the emergency department, as well as up on the floor on the oncology unit, on the med-surg and orthopedic units. So I help with the discharge planners along with my team of social workers and behavioral health therapists. And we make sure that when the patient is ready to leave the hospital, that they have a safe discharge and they have all the necessary help at home, the special medications and equipment if they need it.
All right. So you're also a licensed insurance agent. You know, as I mentioned, that's how we got to know each other.
Yeah.
Just real quick, just so kind of know a little bit about that. What led you to get into insurance as being a nurse in the hospital?
So the bottom line is I really just wanted to make sure that my patients were taken care of. And I was thrown into case management and really thrown into fire to really understand insurance. And in order to learn about that, I started just Googling and went to Kaplan Financial and got my insurance license because it had to do with Medicare. I was listening to a lot of videos from Christopher Westfall, and he another insurance gentleman that started about 19 years ago or so. And he was also a former police officer and went into this business, but excuse me, but he knew a lot of the regulations. And while in the emergency department, in order to know about those regulations, I listened to what he had to say, because that eventually answered some of the family's questions about Medicare and observation versus inpatient and the coverage for that. In order to be the professional that I was, I decided to get board certified in case management 2 years after becoming a case manager. In order to do that, I had to take a test. And what helped me a lot is that little thick book to study for the life and health insurance license. And it allowed me to pass that. So I said, what the heck, just to go ahead and take that test too. And I passed it in the same month. And then from then on, I just went down the rabbit hole and went on all these Facebook groups. When I'm helping patients, I needed to know all different ways for them to help pay for healthcare and home care. And one of them was about annuities. And I found that information about you teaching about annuities through Justin Brock's Medicare Gurus Facebook group. And I actually took your course. and learn about that. And that's how I've been connected with you throughout the whole time. I just listen to all the chatter and the Facebook groups, which helps me answer some of the general questions that the insurance licensed agents ask each other, and the banter, which also kind of helps me guide my patients. So bottom line is, I got my insurance license because I wanted to make sure that my patients were taken care of.
Yeah, I really love that story. Somebody who really kind of goes above and beyond what's required in your job. It'd be real easy to not answer questions of your patients when they have those questions, because you just say, well, I don't know, I'm not an insurance agent.
And
But,
usually when most of my colleagues, the nurses, we always said before that, we always said, oh, the case managers and social workers will help you. That's not my job.
yeah.
But then when it became my job, I had to know the answers. And so I really had to get the right answer because it can cause a lot of, big ramifications downstream if we didn't answer it correctly.
Yep.
So that's what being a professional is all about.
That's exactly right. Yep. That's exactly the definition of a professional. I love that. And I like what you had to say too about Facebook groups. That's been something that I have discovered in the last, 4 or 5 years, since maybe Facebook's became really a big thing as an educational tool. It's such a great resource for learning or getting answers when you need it, networking with people who, there's just not that many of you in my area. We've got 2 hospitals, and you can't walk in and talk to anybody. You can't get anybody on the phone. I mean, not that I've ever tried, but I just haven't tried because I know you're busy, and I can't just call that person up and ask a question about, I don't know, whatever the question is.
Yeah. And I want to make sure that I, whenever they talk to me, I want to make sure that I'm open-ended. So I give them my business card and they said, just call me for whatever question you have. I'll be glad to answer it when I have the time. And so I just want to be a resource to the community. I'd rather have them, call me before they meet me in the emergency department where it is very too late. That's part of the reason why when there's a triggering event and they meet me in the emergency department, I kind of tell them about, let's talk about how you're going to pay for care, because I can already anticipate that you're going to be seeing me several times over. And then I go down my list of how to pay for it. And one of them, again, is the annuities. We go with Medicare, VA, annuities, long-term care insurance, reverse mortgage, yada, yada. So I go down that whole list when they meet me in the emergency department. It's above and beyond what is needed to be discussed.
Yep.
But it really then it really allows me to triage them for all my home care referrals and the community referrals out there. So I give them a call and give everybody a heads up. I create my whole team, and that's part of the reason why I'm even in this this group here, because I learned from the owner operators of other things out in the community. To help them out, so to make their lives easier, so that when I do give them a referral, I understand what the next step is, and also what happens 5 steps ahead, so that everybody kind of wins. The patients are taken care of, and the business owners thrive, which again helps me create a safe discharge plan.
Yeah, that's great. So we've kind of touched on it a little bit, but give me just kind of a day in the life of Eliseo. What do you do at your job, just kind of day to day?
So I things have changed. They rearranged my position in the emergency department, but I used to sit in the corner right by the trauma bay in our hospital. And before I forget, whatever I'm telling you, it's my opinion. It's not the health system that I work for. I'm sure you're going to be able to just look me up on my LinkedIn profile to know where I work. These are my own personal observations working in the emergency department for the past 28 years. So don't hold me to that. I'm not giving medical advice or legal advice. And this is, my own personal opinion. So I sit in a corner where in front of the two trauma bays, to my left is a social worker, and to the left of her is a pharmacy tech. And behind her would be a pharmacist. And behind me would be an internal medicine doctor. And as a team, we collaborate in making sure that we created a plan, a discharge plan, the minute that they walk into the emergency department. I look at the patients when they're being triaged, and if they have a history, a previous hospital stay, I start looking at that so that I can anticipate what they need. If they were to be admitted, I have a guideline, a guidebook, interqual, that I get the algorithm to determine if they're inpatient or observation. And then from then on, we work with the doctors, the physician's assistants, the nurse practitioners, if they're observation, to see if they clinically they remain that way or they can be inpatient. And then we follow them up. If they were to be discharged, then that's where I create all the layers of aftercare out in the community to make sure that they're supported. And then we're going from there. Now I'm upstairs also on the floors and then I follow them up. They're either in the oncology unit and also the post-surgical care, as well as the orthopedic unit, where they would have, after surgery, I have to kind of coordinate with the physical therapist, the occupational therapist, the behavioral therapists, what they would need if they were to go to a skilled nursing facility or they would prefer to go home. And obviously COVID has disrupted that and really complicated that process.
Yeah.
So,
I think most people just don't know how much goes into discharging somebody from a hospital. I know it's easy to get frustrated and the doctor comes in and says, okay, we can discharge you. And 4 hours later, you're still waiting to walk out. But it's because there's a lot of moving parts to getting somebody out of the hospital safely.
Correct. And in fact, I thought I was going to be late for this interview because I really had a complicated discharge before coming over, and I wanted to make sure that it was completely done and buttoned up before I go, because there was a lot of moving parts with it. So it was tough.
And it's really a multidisciplinary event, right? It's a team effort. You've got somebody from every discipline. You're the case manager, but you're working with a social worker, a pharmacist, outside agencies being home health care, skilled nursing facilities.
Right. And including the assisted living, the independent living, the short-term rehabs, the acute inpatient rehab. Most of our patients, it's not cut and dry. They have some mental health issues, some substance abuse issues with no insurance. And then you have to put together a plan out there with no funds and no support systems. They're homeless. It goes to that extreme at some point. But for some in the emergency department, it's a triggering event. It kind of gives the family a little, nudge, a little slap in the face that this could happen again and again. And how will it affect my life, my work, my children, when I have to juggle that, taking care of my 95-year-old parents,
Yeah.
as well as my children and as well as work.
Yeah. Do you do any follow-up with the patients after they're discharged?
No, our ACO follows that if they're part of the accountable care organization. But yeah, that is the biggest gap that I see, because it needs somebody to be the driver to really follow through with that discharge. The transition of care is the most critical portion of the discharge from the emergency department, and unfortunately, I have no one to really anchor to refer them, and that's why I use all the home care referrals, as well as the private home care owner operators, to see if they want to participate in that. And that is what I'm really looking for.
Yeah. When you say ACO, Accountable Care Organization, is that an entity within the hospital, or is that a group of
it's a group of hospitals that take care of that region, and make sure that they're taking care of that population, because they share, some of the patients go to different hospitals at certain seasons of their life, and they want to make sure that they're taken care of properly within the region. It's a group of hospitals that cooperate with each other, because they know that the patient is ultimately needs to be taken care of.
Right. Okay. That seems like a good idea to me. Now, bringing it into our context here with home health care agencies, how does that work? How do you make that connection as far as giving a referral, and then how do you work with them specifically?
So normally, the health systems, or most of the health systems, have their own home care piece, and I would refer to our home care piece. We have after the hospitalization, there'll be a nurse, physical therapist, occupational therapist, social workers that would follow up on the patient after discharge. And if they need private duty, then we have another umbrella that supports that. But the nurse, physical therapist, occupational therapist at home, if they need it, is just intermittent care. And the private duty portion of our health system kind of fills that gap if they're able to pay. Now, sometimes they're so inundated that I have to go to a secondary and tertiary list of community referrals, so that if they need 24/7 care or additional additional help, then it's available. I've already vetted those people out. I've already gone to the community to network. I go above and beyond sometimes on my days off to do the networking, so that I can see them face to face, because sometimes when you refer them, kind of like we've never met, right? But I kind of understand, I kind of know you. It takes time to know you. So if I don't know you, I can't refer, because I haven't vetted you out. I don't know if you're bonded, licensed, if you're just, taking people, employing people with a heartbeat, or you didn't do a background check. Those are the things that I kind of add on, in addition to if I get a green light from our health system to look for additional help for this patient, because we just can't do it because of the volume.
Right. Now, within your health system, so you've got the providers that work for your health system. Does that include non-medical care as well?
Correct.
It does? Okay.
Yes.
Now, that's just a need that your hospital system has chosen to provide. I would I would go out on a limb and say that a lot of hospital systems or individual hospitals don't have that.
Correct, and that's the opportunity.
Yeah.
That I would pursue, and that's what we're in this group for.
Right. Yep. So that's a good point. That to find out, I can think back when we had our first baby. We had him in one hospital, and boy, they were following up and coming to the house a couple of times within the first 3 or 4 weeks. And then when we had our daughter in another hospital, we just really didn't get anything that was proactive. And so I can imagine that they're set up a little bit differently and set up for that purpose.
So what I'm finding out with that, Ron, is that even the national companies like Bayada or some of the franchisees and just the regional players in my area here, they're so inundated that they can't accept my referrals. And our catchment area where it's farther and farther from where our hospitals are, I have to find those different zip codes and try to figure out who is able to provide that care, and it is tough. It's a function of not having enough caregivers who are special to provide care, or people just don't want to work, or it's just backbreaking work, or they're not getting paid enough. So
I think it's a combination of all the above.
Yeah.
But
it's really making it difficult for me to discharge patients safely, and so that's why I go above and beyond to make sure that I have a stack of business cards so that I can just go down the list and see if they can provide layers of care out in the community.
And I would imagine you have that stack of business cards sorted in some kind of priority. You got your favorites on the top and you work your way down.
Correct. So the pain point, or my pain point as a discharge planner in the emergency department, is usually at Friday at 4:00, and it's going to be holiday, and it's going to be a holiday or during the weekend. So when I go down my procedures and my own home care company is not able to provide staffing within a reasonable time, I go down the list and I start calling. I just go down the list, leave a message, and then whoever's first, I talk to, because the first top 10 I've already vetted out, right? So whoever gets that, whoever calls in first, I ignore the rest, because they better take care of the patient, right?
Yeah. So
that's how I've worked.
So would you say it was important to answer your phone when somebody calls?
Oh, heck yeah. It's speed to lead.
Yeah.
And the lead, I have to go down that rabbit hole too. The speed to lead. Yes, you can answer my phone call, but if you don't have the processes to follow through and vet out, let's say, my lead, first of all, we can jump through hoops to put together a plan. But if just before you have the caregiver come in, all of a sudden they change their mind, that's just business. I can't, on my end in the hospital, I've already edified you. They're great. I've already vetted them out. And they have a caregiver ready and waiting at your home, and then they change their mind. And unfortunately, you kind of have to play that game, because the ones who did follow through, later down the line, they say, that patient that you referred me to 2 years ago, well, they're still my patient. They're still my client. And that is really what, you had a hand in it, meaning that you took care of that client for 2 years, and yay for you. But because you listened and you kind of, took the initiative to answer my phone call.
Yeah. Now, so you call somebody and they answer the phone, and then are you expecting them to have a process for
Uh,
handling your phone call in the first place?
yeah, so they will get a summary of what the patient is, what the patient has, what services they need, and bottom line on my end, I want to make sure that they have the ability to pay. Um, and I let them know that because I've already done the discovery portion through my own triaging at the hospital. And again, you see that I'm all different. I'm all in these different Facebook groups because I go above and beyond that to really support the businesses that I refer to. Uh, if they have long-term care insurance, have they gone through the elimination period? Are they in service? Are they working with another company? And even if they were working with another company, do they still have a gap of care that you can slide yourself under there because people change their mind and the other company may give them poor service or poor caregivers that they are willing at that moment to change their mind and try another company. Uh, so get in there. Just whatever processes that you need to do to get in there when it's your time for me when I call you needs to happen. Work that out business wise. And one of the things that uh, the other home care company owners ask me what they should do, I tell them have a runner because when I give you a lead or when I give you a client, you're going to be taking care of them, whether they change their mind or whether it's an hour later. You need to follow up and follow through because you already know that there was a triggering event. There was a discussion of what will happen. I can kind of tell you what's going to happen to them based on what they came to the hospital for, and you just need to follow up. And it's all yours. That's add that to your CRM, your database, and talk to the power of attorney, the children,
Mhm.
because it's inevitable that they will
Right.
need
So
help.
just because they changed their mind and didn't actually hire you at the moment doesn't mean that they still don't have the need and,
Correct. And
and won't hire you later down the road.
right, they're going to go through the natural progression of, hey, we have 4 kids. We're going to try to round robin and take care of mom and stay there. You stay there for a week, and you stay there for a week, and you stay there for a week, and finally go, I can't do this. So then there's your moment to shine, and because you have followed up and stayed top of mind.
Yep. Yep. I agree. We have a question from the Facebook group. How many companies do you work with? So your stack of business cards, how deep is that?
Oh, I should have put that to. It's about this thick, but when I call them and they're no longer in service, then I just toss it out. Right? I check on them. There's about 400 in my area. Okay,
Wow.
so you really need to stand out. You really need to try to contact me through email, Facebook. I want to know the way I know about you is, do you hang out in the community and do community events? Did you connect with me on LinkedIn? Did you kind of go to the emergency department and send me a little token, right? Like little gift basket or something, like just, hey, just stopping by. I can't meet you because we're so busy, but you become top of mind, right? In the holidays and little here and there. And what I do with those is that I share them with my social workers and like, hey, who gave those? And so I give them a little spiel, right? Um, of who it was. Um, and we kind of monitor the activity out there to see who's the most active and who's the most benevolent out in the community. So
Okay.
that's how we know.
How do, especially in the COVID world that we live in now, what's the best way, and what's your preferred method for agencies, marketing managers from agencies to contact you and start building that relationship?
The email at first, and then just give me a call, leave a message for the moment. If I have time, then I'll do what everybody who's being cold call done. I look at your website. I take a look if there's anything else that kind of anchors me to make you unique. If you have a podcast, if you have, a community event or a CEU that I would attend. I like attending CEUs because it kind of, sometimes they sponsor an elder care attorney, other nurses that have specialties. The one was even Teepa Snow to talk about dementia and those kinds of things. But really, the CEUs is really what gets me out in the community because first of all, I need it. And then that's when you're able to see me. And
so I picture you being really, really hectically busy when you're on a shift at the hospital.
Absolutely.
So honestly, now I want to put you on the spot here, and you can answer or not. I won't hold it against you, but do you read cold emails from home health marketers or answer phone calls?
Yeah, when I have the time, I really want to connect with you because again, I just don't know when I'm going to be able to use you. But bear in mind that when I use you or when I contact you, I want you to be responsive and I want you to be able to take care of the patient. And on the back end, tell me, here's the referral that you sent me. We're taking good care of her or him, and they're thriving. That's what we love to hear. That's what the social workers want to know. That's what the discharge planners really want to know because we don't know once they leave the hospital. So if you give that is the critical part of just showing us that you took care of that referral.
I'm taking notes, man. You got my dad here.
So going above and beyond, if you were in this area, Ron, this is what I would do. In fact, I shadowed for about a couple of years a non-medical care homeowner, business owner, and they also had an adult daycare. So that's and I learn about their operations so that I can really understand what is a good referral. How are they being taken care of? What does physical therapy within the adult day center consists of, and how are they charged? And that's what I wanted to know. Which part of Medicare is will they be charged for? You're right. Whether they're Plan N or Plan G, the supplement or the Medicare Advantage. And so when I understand that, and that they have the right or wrong, for lack of better, right or wrong insurance, or when I spot check in that they have, let's say, original Medicare or the Med Sup, I know that they're going to be taken care of. Whereas there's so many variations of the yearly with the Medicare Advantage that I just kind of sometimes just throw my hands up in the air and I'm like, okay, unless I actually see the explanation of benefits, summary of benefits, and what changed this year, it boggles my mind. I don't have time to go look into that, but the care I understand with just the original, even if I just have original Medicare as a template, I understand how they're going to be charged. And it's easier for me to kind of tell them, here's the step. If you're having a wound care, this is where it's going to be charged, and this is your copay, and so on and so forth. So
Yeah.
make my life easier.
So I'm just going to assume that you're the exception to the rule. Is that fair? That
Yeah.
Because you go, I mean, you really go above and beyond. I think everybody listening would agree with that. So in let's say your average hospital system and your average caseworker, case manager in a hospital system, where does somebody like me who's just getting started in this home care business, where do we start getting in there and start to build that relationship? Who's the first person we would contact?
Some people just, some of the liaisons just, or business developers, just stop by in the ER, and then they give pamphlets, and that's how I get to know, hey, somebody else new. Let me take a look. Let's see how well they perform, and then you just keep seeing it over and over and over again, and then I start looking. I start doing my due diligence. I check to see their background, and if they are referred by other vetted community partners out there, that's when I go, okay, let me put them in my list. If they don't, if our umbrella doesn't cover it.
Right. Now, can we just walk into an ER and meet somebody?
It used to be, they just, what they would do is just have a little pamphlet or a little trinket and say, hey, can you just give this to social workers and the case managers and the registration clerks usually bring it back in the back, and then that's how I know. Some drop off the donuts, and some go above and beyond, know that the social workers and the case managers and also the ER nurses are on a diet. So they bring a fruit tray instead of like the regular donuts or the coffee. So, and what I do is I just give it out to the staff because you get so much, but then it gives you become top of mind.
Right. So persistency, showing up every week, every month, week, and then probably follow that show up and that drop off.
Right.
Follow that up with a phone call and an email, probably.
Right. And if you are networking with them during the CEUs, then you put a face to the emails, the drop offs. Right. That's how we do it.
Do you have it like any don'ts? Like what would absolutely turn you off and say, okay, I'm never going to work with that person?
There's been a few where they would just show up and tap me on my shoulder. For whatever reason, somebody let them in. They thought they were family members, and they would walk into my space. And I go, how the heck did you get in? Like, who are you? And they do that 2 times. Yeah, no, they're I'll call security because they can't stop me from taking my time to take care of patients.
Right.
They can't do that.
Right. Okay.
So that's the main one that oh man, that's just terrible.
So we show up with a 6-pack of beer or something like that.
No.
Against the rules.
No. I'm really friendly with them because I understand that they have a job to do, and then they have to have metrics and just okay, but you only have a minute or two, and that's it. But if you see me again, and the community, the open houses, the grand openings, the CEUs, the community events, when you meet me there, say hello.
Okay, good. Do people invite you to lunch and coffee just for one-on-ones?
Yes, only if I've time to do that. But that's what the short-term rehabs, the assisted living, the independent living facilities have like a continental breakfast, uh, drive ups, drive throughs, dinners at 4 o'clock, you just to say hello.
Mhm.
Those help too because um, it allows you to see them face to face.
Are you a little bit more relaxed now here in the second quarter of 2021 as far as COVID goes? And most hospital workers, I would guess, I know in our area they're vaccinated to the extent that they want to be. But how's that going in your area?
We're actually seeing a resurgence,
Are you?
and yeah, even the vaccinated ones. Some people are letting their guard down, and yeah, my wife is seeing that resurgence in their ER. On my end, same thing. Um, so just be very wary, you know.
Yeah.
But we're able to kind of see the pulse because we see the volume that's coming through the emergency department. And let me tell you something. The discharge planner, just for the group, a busy emergency department, numbers wise, is about 150 to 200 people
Mhm.
per 12-hour shifts per day sometimes. And so that is the opportunity that I'm able to provide for you if for discharge planning. So I review those charts from the beginning. And so I'm the first person that will kind of tell them and anticipate their healthcare trajectory. Also, because of my 20 years in the ER, I will see them back and forth again. So I make sure that I have a secondary and tertiary uh, support person's phone number to be able to pass on along to you because they need that network of caregivers down the road. So that's the volume. And the 2017 study from University of Maryland, I believe, shows that almost half of American healthcare is processed through the emergency department. And I'll pass that along too.
Hmm.
Um,
Okay.
yeah.
That's
So,
interesting.
and that's why I see it all the time, and that's why I'm able to kind of predict what what will happen to them.
Right. That's interesting. Now, how we kind of skipped around in my list here because you're really good at answering these questions. Uh, as you're going through your Rolodex, looking
Yeah.
for somebody to refer to, does it are you looking for specialties also? So say a home health company specializes in taking care of somebody with a stroke or with Parkinson's or with active COVID.
Yep. Yep. Some of the physical therapists focus on Parkinson's. Some of the physical therapists work with dementia patients. Believe it or not, some of the occupational therapists I send out to take a look at the layout of the homes because of somebody is having strokes. The um, the inside scoop is start looking at the aside from the emergency department is the acute inpatient rehab facilities. Make yourself available there. The acute inpatient for the strokes and multiple sclerosis, those types of neurological injuries that really need support, layers and layers of hands-on care. Because what I'm seeing now, well, I was telling somebody else just recently in another interview, when I take a look at the emergency department, most of them are in their mid to late 90s that are coming in and inundating the 40 beds, the 50 beds in the emergency department, and they're admitted. So that is what I'm seeing. And most of the support systems are in their 70s. And now most of the caregivers are now the grandchildren that I have to add on to the CRM or the database to call, so that they know who to text if their mailbox is full, or they know how to knock at a door to say, hey, the hospital is trying to get a hold of you, to make plans for the next step.
Right. We all want to make sure that we're always doing a good job for our patients, our clients. That's goal number one. Secondarily to that, I know that hospitals are kind of graded on their readmission rates.
Mm-hmm.
So and potentially penalized, especially by Medicare, for having too high of a readmission rate.
Right.
So that's one thing that I want to really kind of address with my referral partners and specialize in, is keeping people at home for longer, keeping them out of the hospital.
Right.
And through various different means, like rearranging the house, or adding ramps, and getting out fall hazards and things like that. Would you think that's a good way to go as well?
Yeah, absolutely. Be part of that team that I refer to, and it's just not me; it's all the other team players out in the community, because no one person can provide care for that patient or the family. And that's the reason why I tell you that just be part of that referral team. So let me go to a typical referral. I refer them to you as a home health care agency, non-medical home care, let's say. Beyond that, I want to know how they will be able to pay if I go deeper to see if they can go use the VA to pay for it, if they had the annuities, if they had the long-term care insurance, if they have cash, or somebody else will be able to pay, or if they bought like a hospital indemnity product, or a home care policy, right? Home health care policy or short-term care policy. I go through all that. And if they have an estate issue, I refer them to the elder care attorney. If they have any other legal matters, family dynamics, I refer them to the elder care attorney. So it's a whole host of community referrals that start out from me, because that triggering event in the emergency department or the hospital allows me to kind of hone into the people that I've vetted out there in my Rolodex.
Right. So that kind of leads me into the next question: is what does an agency do to maintain that relationship long term, besides just answering the phone and being available when you need them? How do we make sure we're maintaining that stream of referrals from your end? What's in it for you, I guess, is we can kind of
What's
that, but
so what's in it for me is basically to just take care of my patients well. I love my grandmas and grandpas, and they deserve, they're not disposable. They need the support. It's almost, for a lack of a better word, or a description, is that they're almost like a toddler, right? And you want to make sure that you provide for them and take care of them properly,
so provide that good, high quality, caring care.
Yes.
But the way that that is because we're communicating with you on the back end.
Correct.
Yeah.
Correct. Yeah, I've seen some caregivers that have been with the family for 9 years, because of that they become part of the family.
Mm-hmm.
And how do you get to that is really just understanding the family, providing the creating that culture in your business, in your employees, to provide that care. And, you know, the margins are just there
Yeah.
to
Yeah.
be able to create a great business.
What's the best way to ruin one of those relationships?
And not be responsive, and leave me in the dark. And also, it trickles down. It's a small world, this medical field.
Yep.
All the facilities talk about you. If you provide poor care, it may not be blasted out, but it eventually comes back to me. It eventually comes back. The patient comes back again. The 50% of the care, they come back to me. The patients and the family members would say about the facilities that they would not send their dogs there. Oh, that person that you referred me to was terrible. They All they did was sit on the couch and play on their phone. I had to coax them to really help out, and I don't even understand why I was paying them.
Mm-hmm.
I could have done that myself. Or some of the caregivers would just refuse not to do things that they hired them for that was part of the package. For example, just do basic laundry, change the light bulb, or just be available, or just, they would be found sleeping. So, uh, yeah, run your business right.
Don't do a bad job, and
Yeah.
you won't get any more referrals. Now, one other thing is, I've been of the opinion up till now that it's probably not the right time to approach a hospital until you're ready, until you have the ability to be responsive and
Right.
have that care available right away. What's a time frame like when you're discharging somebody? How quick are you expecting them to have an aide in the house?
Usually within a couple hours. Sometimes I've seen from the emergency department, sometimes within the hour. And that's why you need, I would encourage somebody to, if they're owner operators, if they at least intake that person when they get home, because I need to clear my emergency department. I want them to be that responsive within half an hour. Sometimes I give them leeway of 2 hours to create that caregiver. But again, it's a logistical nightmare. I understand. But if you have somebody and as a runner to do that initial intake, as well as, and may unravel, it happens. Or, they would come in and your minimum is 4 hours and they only wanted two. Whatever that is, figure that out as a business person, to make the margins, and just understand basic business principles. The main thing that I see is you put the plans together and your caregivers don't show up. That's another thing that that happens. And then since nobody is at home and they live alone, they come back to the emergency department. The whole process starts all over again. And yeah, that
Yeah,
is really not a
that's a
good thing.
chronic problem in the home care business. I think you know that. And
Yeah.
we as agency owners have to address some way. And, I think part of that is, minimum hours and, higher pay than the average
Mm-hmm.
care. It's a good way to start, and treating people decent. But so I think what you're saying is I don't necessarily have to have the caregiver there within an hour, but I need to have somebody there to start the intake process.
Right.
Right. Okay. Good.
And in the intake process too, it can be helped, because you're asking the same questions, the same basic questions that I've already asked in the hospital.
Mhm.
So I can be nice and give you the same information with the patient's permission, so that they can just take a look at their records. I'll give the records to the patients, and then they'll, uh, show that to you so that you can just read it and fill in your intake form. That would help out. That's what I know that they would hate to do, because they've been asked the same question 20 times. So the same
Yeah.
questions.
Yeah. And
They're just basic demographics.
yeah, I know. I don't like that either. answering questions over and over again. Even in a doctor's office, you fill out the stack of papers
Yeah,
and
it's ridiculous.
write your name and social security number 6 times. But I think that, anything we can do to streamline the process, because it is a sales process. When you're talking about private duty, private pay, we have to sell our services to the patient when we get there. It's not just because Eliseo said you need home care, doesn't mean they're going to buy it. So
and what I do on my end is I sell as I edify you. If I know you and you've told me enough information about you, and that you've given me good service in the past, and some of the clients to tell me, I edify you. I tell them, hey, listen, I've been working with them for quite a while, for 3 months or so, or a whole year, and I've vetted them out. They've always had great reviews, and they hang on to that. So whatever you can do for me to be your megaphone, by meeting me and kind of introducing me yourself to me, because again, it's human to human. It's H to H instead of B to B, B to C. Yeah. It's a H to H, right? Human to human.
Right. So I've got one last question, and then we've got a couple of questions from the comments, and then we'll wrap it up. We're right at an hour now. I don't want to keep you much longer. I really do appreciate your time. Am I right in my belief now that you work in the ER, but you have a counterpart upstairs after people have been admitted, or is that one person that handles both?
No, I go all over the hospital.
Okay, so you work with not only people that are being discharged through the ER, but also being discharged after having been admitted?
Correct.
Okay, so it's not two different people we have to work with.
Sometimes when I started out in the ER, I was strictly ER. Yes, there's a counterpart upstairs. Okay. And there's a counterpart that I refer to the ICU, and then they just get downgraded to telemetry, then to the med surge. So there's different counterparts in different floors.
I see. Okay. So each floor section, however you divide them up, as a case manager.
Correct. A case manager and a social worker. They usually work in tandem because it's just not strictly medical. They have behavioral and substance abuse issues.
Okay. Got it. All right. A couple quick questions. If you've got just a couple more minutes.
Sure.
What's a good community event? Like if you had to pick one that you were going to go to, where would you go? Where could we go that might have a couple of case managers or social workers attending?
Updates from the elder care attorneys with guardianships and legal case studies. That would really help us out, because we deal with tons and tons of moral and ethical issues that sometimes lead to the referral to the elder care attorney. So some of the home care companies sponsor those.
I'm just kind of coming up with ideas as we're speaking about this. In my insurance business, that I do seminars. I teach people about Medicare. So that's one thing that I've been thinking I might do, is partner with an elder law attorney, and maybe even a CPA, and maybe a social worker, a hospice company, and do a community-wide seminar where we invite not only end users, but practitioners.
Yeah, I've been part of that too. They use me, and then I'm almost like a chameleon, because I can talk about Medicare, and I can talk about the medical process, and then I could do about referrals and marketing. So,
okay, excellent. And then we had, let's see, I think we covered this in the beginning, but how often would you say you refer to non-medical? So if I can put
every day.
Every day.
Every day.
So I think the context of that question is medical versus non-medical.
So it's a continuum. Let's just take, for example, the Medicare patients, that when they come from the hospital, it starts out with the RN, nurse, the physical therapist, the occupational therapist, but it segues into non-medical after that. because they can't be left alone. There's a lot of 90-something year old patients that live alone and they still drive, and they have no extended families. And how are you going to find that out unless they get sick? They usually don't come to the hospital, but when they get sick, that's when we find out that they don't have the support systems, and that's where you're going to start the process.
Yeah. Okay. Well, man, that is great. Is there any question that I should have asked you that I didn't?
No, there's so much to learn. The main thing is that it's a marathon, not a sprint. Just to get my attention to refer somebody to you, you have to be doing some great work to for the other community referral partners, for them to refer to me to be able to start, you know, being part of the team.
Yeah.
And
On
if
average,
you're,
how long would you say it takes from the time from first contact to your first referral?
months, I can't,
Months.
yeah, because I'm so busy that if you're not top of mind, then I just forget you. I have when dealing with the volume that we do, like say 150 to 200 patients a day through the emergency department, or caseloads of 25 to 30 up on the floors, my attention span is very limited.
Yeah.
Unless it's all about getting a safe discharge happening.
So if I contact you once or twice and don't get a referral, I shouldn't get offended.
Correct.
Just keep at
it. Just connect with me all different ways. Again, LinkedIn, I tell everybody to just connect with me on LinkedIn, and then kind of, communicate with me that way, because that's what I do. Oh, the other thing that I do is I put you in my personal cell phone so I can text you. I'm ready to, like, I have a referral. I have a referral. Do you cover this area? And then we start the banter right there. But so I start at 7:00, and first come, first serve.
Yeah.
Right. But you have, I don't know how that will look in your business, but I'm like ready to go from 7:00 on.
Yeah. Very good. Well, Eliseo, thank you so much. I really appreciate your time. I know you're very giving with information in the insurance groups, and I appreciate you coming in here and taking the time to educate us a little bit from the other end. I don't think I've seen anything like this interview in the home healthcare groups that I've been watching. So this is a unique experience for all of us. I really do appreciate it. Thank you very much.
Oh, you're welcome, and I appreciate you having me on.
Great. Okay. Well, that is about it. We have been going a little bit more than an hour, and we're going to let Eliseo go, and we will see you guys in the group. And be sure and he's in the group. Ask questions. Don't kill him at the hospital. Ask him questions in the Facebook group. I know that he's real active in the other groups that we're in, and he'll. I think he's happy to answer any questions that we have to the best of his ability. So again, thanks so much, and have a good evening. We'll see you.
You're welcome. Take care, guys.